Live.
Hi, everybody. Thanks for joining us today. This morning, we're going to focus on mostly exercise and cystic fibrosis. We have 5 really exciting abstracts for you guys. So we're going to get the presentations done, and then we're going to have about 8 minutes after each presentation for an opportunity for us to ask questions directly to the presenters. So our very first presenter that we have is Laura Russian. She's a respiratory therapist at Dell Children's Medical Center in Boston, and she's going to be talking to us about adherence with home spirometry.
Hello, my name is Laura Russian, and I am a pediatric respiratory therapist at Dell Children's Medical Center of Central Texas in Austin. Joining me today is Kathy Villagomez, Program Coordinator and Respiratory Therapist from the Adult CF Center of Central Texas, also in Austin. We will be presenting our center's abstract titled Improving Home Spirometry Adherence for Outpatient Cystic Fibrosis CF Clinic. Poster number 265. We have no relationships to disclose related to this presentation.
With the COVID-19 pandemic hitting in spring of 2020, the Central Texas Cystic Fibrosis Centers halted in-person CF clinic visits, which included spirometry testing. Through these challenges, this project began with the aim to improve the percentage of patients submitting home spirometry data prior to or during their telehealth visits to over 60%.
This process began with identifying our patients with home spirometers and telehealth visits during the data review period. We developed a spreadsheet combining both our pediatric and adult patients to ease tracking of home spirometry telehealth reports.
Initial communication involved contacting patients via email or phone prior to the telehealth visit, with a reminder to send home spirometry data before or on the day of their telehealth visit.
If a report was not submitted, follow-up communication to the patients by email or phone after the telehealth visit was conducted to obtain the spirometry data. As reflected in the photo from this slide, an additional virtual visit was set up to collect spirometry results for that visit. Virtual visits like this one were optional but highly encouraged.
The number of patients that supplied spirometry data prior to or during telehealth visits and any initial and follow-up communication related to obtaining spirometry data were tracked.
Between October 1st, 2020 and March 15th, 2021, we had a total of 184 telehealth patient visits. Of those visits, 140 patients, roughly 76%, submitted their spirometry results prior to or on the day of the appointment. Follow-up communication occurred on 34 of the 44 patients that did not submit a spirometry report. 12 of these patients submitted spirometry results subsequent to the follow-up communication, bringing the total submission to 83%.
As respiratory therapists, we recognize the challenge in obtaining this information, as many have already expressed some virtual fatigue. Several patients did not have devices on hand during their telehealth appointment. Many patients did not have the device prepped or the appropriate app installed. Multiple patients also waited to perform the spirometry testing with the respiratory therapist during their visit. We realize proactive communication with patients prior to clinic can help to overcome these barriers.
In conclusion, our centers experienced some challenges obtaining results in a timely manner for their telehealth visits. This project highlighted that simple interventions via phone call or email surpassed our initial expectations of 60% to 76% of spirometry reports submitted.
At the time of this project, our team continued to communicate with families and address the barriers we encountered along the way. Moving forward, we have set a new goal to receive spirometry results from at least 80% of our patients prior to their visit. Thank you for joining and taking the time to listen. We hope you have a great day and learn many new things. Until next time, bye.
Okay, thanks. I hope everybody enjoyed that. I realized I forgot to mention to everybody that if you guys have questions, you guys should be submitting them through the online portal so that we can see them on the back end. But other than that, let's switch on over. I know Laura's here to answer some of the questions that we've had come in already. So Laura, thank you so much for that presentation. We appreciate it. So one of the first things that I think comes to mind for people is that everybody learns so much with, oh, sorry guys, I have one more mistake that I need to own up to. Dell Children's is in Austin, not in Boston. And while they sounded similar when Laura was telling me that, Austin and Boston are very far apart. So Laura is in warm Austin, Texas, not in Boston, Massachusetts. But anyway, yeah. So Laura, the first question is, now that telehealth visits seem to be dwindling, what else did you guys learn from this project? While we know telehealth isn't gone forever, what did you learn that you feel like you can carry over into the world of mixed visits or in-person visits and telehealth visits?
Yeah, I mean, it was a lot of fun doing all of that. I will say it gave us a chance, especially for our really young kiddos, that we were going to lose that time of training them and teaching them. We had that option to do that at home and work with them and their parents, and we'll continue doing it. We still have to a small degree, even though we are mostly back in person, but we still do utilize that since we have it. Most of our families do have the devices at home. So yeah, it's going to continue. We'll keep using it just like we did before.
Okay, sounds good. Some of the other questions that we have are, do your patients plan to continue using home spirometry even for in-person visits or only for the telehealth visits?
Yeah, it's primarily for the telehealth visits, but there are a lot of patients that reach out to me directly. And if they need just some extra support or teaching with the device, we might even have patients who we do see in person, but then we might want to get a set of PFTs a week later, and we utilize it that way.
Okay, great. Next question. Who was doing the outreach? Was it the respiratory therapist? Was it the center nurses? Who was it that was reaching out?
Yeah, it was us. It was me. I have another RT here in clinic, and on the pediatric side, we were doing it. Primarily, I was the one reaching out to our families, and then Kathy Villagomez, who was also with me on that presentation, she did all of that with the adult patients.
Okay. And how far in advance of the telehealth visits did you feel like the results from the home spirometry were feasible or appropriate to apply to that telehealth visit?
Well, we reached out about a week before. Ideally, we liked to get them on the day of, but we had to be flexible. A lot of families had to do it the day before. Some of the teaching took a little bit of time, and so we were trying not to use too much of our clinic visit time for that. So sometimes it was the day, maybe day or two before, but yeah, I mean, ideally we wanted to get the results on the day of.
Okay. And did you guys have the opportunity to compare the results from the home spirometry to the results in the spirometry lab at all?
A little bit. We didn't during most of 2020 when I didn't have access to a lot of our equipment in the lab. I didn't have access to a lot of those numbers that I would have liked to have had, but we have done a lot of that since then, and we've compared some results.
Okay, interesting. Be interesting to see that. Also, were the patients only using it for pre-clinic visits, or did you have a recommended frequency for the patients to be using the home spirometry between clinic visits?
We did. I mean, it was, of course, optional, but we were recommending to try to use it initially, once a week in the beginning for at least a month or two to get used to the device. But it wasn't everyone, but that was certainly what we were trying to do to try and establish a trend.
Okay. Did you run into anybody that was using it too frequently? I know at our clinic, we had a couple of people who were like, wow, 300 uses since like 2 weeks ago. Okay.
Yes, there were a few times I would log into the dashboard and I went, whoa, okay, she's done it 60 times in 3 days. So yeah, I had a few patients like that, not many, but there were quite a few who did that.
Yeah. Okay. A more specific question. Someone is asking what units, like what I'm assuming they mean spirometry units were you using?
What do you mean spirometry?
I guess the brand.
The Mirror Spirobank, the actual device, or the applications we were using?
It says what units were used for home spirometry?
I don't know really what units they're referring to. Sorry.
Okay. I think it was asking like, was it I'm forgetting the names of the different, like there's a couple different companies that make home spirometry units. What brand were you guys using?
I guess the Mirror Spirobank was the one we were using, and then we would alternate between that app or the Zephyrix Breathe Easy app, but I'm not sure if that's answering that question or not.
Okay, yeah, I think so. Yeah, it's a model and brand later. Okay, and then someone was also asking if you're using the Zephyrix dashboard.
I still actually use that. It hasn't been the favorite with a lot of our patients, but I will say, I still encourage that app for a lot of our little kids who are still learning, because there's games on there and there's just different things to try to engage them in using the device.
Even some of the adults enjoy the games. Yeah, I'm a physical therapist. I just know that in passing, them mentioning it. But okay, and then someone else was asking, in addition to just routine spirometry, did you use the home spirometry to help identify exacerbations?
I think some of our physicians did. I mean, we certainly had some situations where some numbers were lower than we anticipated. At that point, we were trying to get patients back in, but yes, I believe so.
Okay. And does the spirometer that your patients were using, does it have CF reference values?
I believe so, yes.
Okay. We have 1 minute left. And one of the questions early on was, did some of your patients already have home spirometry units prior to this rollout project?
Very few. I can think of a couple of patients who did, just through research studies and whatnot, but I would say maybe, 4 or 5. It wasn't many, at least for the pediatrics. I'm not entirely sure. Our adult patients, I think, had some, but certainly not many of our pediatric patients.
Okay. Well, I think that's the end of our time here. So thank you, Laura. We're going to move on now. We've got Lisa Morrison, who is a physiotherapist at the West of Scotland CF Adult Unit in the UK. And she is going to be helping us identify appropriate exercise professionals to support exercise habits of people living with cystic fibrosis.
I'd like to thank the organisers for asking me to present today. My name is Lisa Morrison. I'm a principal physiotherapist at the West of Scotland Adult Cystic Fibrosis Unit in Glasgow. Today I'm going to present on Cystic Fibrosis Active, a project looking at introducing alternative exercise professionals to support work done by clinicians in enhancing exercise habits in people with cystic fibrosis. There are no relationships to disclose related to this presentation. So we've seen previously that the provision of supported exercise or supervised exercise sessions enables a person with CF to fully participate and to gain much more from a session. And when that supervision starts to deteriorate or starts to reduce and expects the patient to be self-directed, we lose something in the clinical outcomes and the ability to participate more fully. So this project looked at the provision of one-to-one support and how accessing physical activity environments or classes locally would impact on the person with cystic fibrosis. So would it improve lung health and general well-being? Would it improve their confidence in being able to exercise? Would it enhance their knowledge relating to what exercise-related activities they could participate in, and subsequently, would it enable the development of an exercise habit? So by introducing the exercise in a local environment rather than in the hospital environment, could we actually impact positively on the exercise habits of the person with cystic fibrosis? We also wanted to look at what information is required by fitness professionals. And in this case, it was students attending the Kelvin College in Glasgow, studying health, fitness and exercise, and what information they would need to support a person with long-term chronic ill health, specifically in this situation, cystic fibrosis, and how that would enable them to recognise the choice of activity that they would need to consider for these patients, the commitment they could offer the patients and the patients could offer them, and to recognise what barriers and challenges people with cystic fibrosis experience when they're expected to exercise on a consistent basis. So we have 290 patients with cystic fibrosis attending the West of Scotland Adult CF unit. And in the run-up to the recruitment process, in the 3 to 4 months prior to this, those people that attended the outpatient clinic were asked if they were interested in exercise. If they said they were given patient information leaflets and the protocol for the project to look at their leisure. And we asked them to return a tear-off slip indicating their intention in a stamped digest envelope to send back to us. If we received information from the patients to say they were interested, we subsequently contacted them and invited them to attend for baseline measurements. Thereafter, we introduced them via email to their personal trainers or the students, and the meetings were arranged at a place convenient to the two parties. Sometimes complementary gym access was required, and that was provided where necessary. So over the 3-year period, depending on the size of the year group, 30 participants were recruited. So generally 10 students per year, as I say, depending on the size of the year group, were recruited and paired up with patients with cystic fibrosis attending the West of Scotland unit. We anticipated a 26 period of evaluation and fitness training over the 1-year period for each 10 patients. The students were also required to attend a workshop in cystic fibrosis, and we facilitated that from the hospital with a CF clinician, doctor, consultant, a specialist dietitian and the physiotherapist myself went to the college and delivered this workshop. We looked at the fundamentals of cystic fibrosis and more specifically what a respiratory exacerbation looked like, how that would impact on exercise opportunities. We also looked at nutritional needs of an exercising person. We looked at CF-related diabetes and how that would impact on exercise, or how exercise could impact on CF-related diabetes. And we'd spent a lot of time talking about cross-infection and ensuring that patients with CF did not exercise in the same gym at all, and to ensure that the cleanliness of the gym was pivotal to ensuring the safety of the individual with CF. Again, as I say, we introduced the student and the person with CF, and the tutor and the physiotherapist, again, myself, acted as liaison between the two groups. On occasion, this meant we went to the local gym to participate in the sessions to ensure that the communication between the student and the person with CF was good, and that we're checking that they were progressing along the right lines and everybody had the support and information they needed to get as much out of the study as they could. The patients consented to the results of some of their routine assessments being collected from their medical records, and that was prior to the study starting. And in addition, we looked at the assessments at baseline, so that was -2 or 0 up to base 0, and weeks 26 to 28, which was the end of the intervention. We looked specifically at the FEV1 and FVC. We looked at the cardiopulmonary exercise test results, so VO2 max and work rate. We also gathered information on 6-minute walk and health-related quality of life indices. Antibiotics both before and during the course of the study were looked at, and in a subset of patients we were able to collect data on lung clearance index and forced oscillometry when we had the equipment available to us. So out of the 30 participants that we recruited, only 19 completed, and we had 11 withdrawals. These were for a multitude of reasons, and that was lack of engagement. So on occasion, sometimes the student lacked engagement or was otherwise preoccupied, or the patient just felt that they weren't having the same interest in exercise or interest in the project. 2 of them felt that their musculoskeletal pain was exacerbated and were unable to continue. 2 of them had a respiratory exacerbation, which they felt that they couldn't continue with the exercise thereafter. And 2 of them just felt that timetabling around their own work and home life was too difficult. Unfortunately, there was no statistical differences between any of the parameters, primary or secondary outcomes measured at the beginning or the end of the intervention. And there were no differences in antibiotic usage, lung clearance index, or forced oscillometry either. This was particularly disappointing as subjectively people with cystic fibrosis reported that they experienced benefits both physically and mentally. And despite this, we found, like others before us, that there was no difference in rate of decline in respiratory function, VO2 max. But as it needs to be highlighted, even in small numbers as such with this study, that they did experience personal gains and overall wellness, but that can't always be objectively measured, as we've seen in the past. However, following the semi-structured interviews, we felt that positively, several of our people with CF reported that their gym attendance increased 2-3 times a weekly, despite previously not attending a gym at all. So that was a definite plus. We also found that they developed positive relationships with the PTs, which helped motivate them to succeed and fully participate more. 2 of the people with CF felt that their resolution of their musculoskeletal issues occurred due to the training. And I think on those occasions that was due to the students having a particular interest in strength training and enabling the people with CF to focus particular muscle groups and enhance the muscle strength around a joint, for example, the shoulder joint, to improve the strength of that joint and subsequently the pain-free range of movement. So that was a real positive. 4 felt that a reduction in anxiety and consequent improvements of sleep occurred, which again is a knock-on effect of exercise and a very positive one. And a couple felt that having a tailored program specific to them was interesting and challenging and subsequently more enjoyable. So those people that felt that the exercise was tailored to them, they felt that the students had an interest in their health promotion and they were able to participate a bit more fully. Their confidence increased, and many felt that they were able to participate in the development of their exercise programs, and they were pushed beyond their previous comfort zone. So they felt that they really excelled at something that they previously hadn't been able to do. Many also reported an increased strength and fitness, so that their activities of daily living in the home were easier to achieve. And then the knock-on effect of that was that they had ease of participation in their exercise sessions. They were more achievable and subsequently more fun. Again, all these things are positives that often we can't measure because they're not easily measured. The quality of life data that we did look at did not show, again, statistically significant results, but we did see between 22% and 55% improvement in these 4 domains of physical functioning, body image, emotional state, and respiratory symptoms. But as I've said a couple of times now, that sometimes these small achievements and improvements in mental health and physical health and emotional well-being that the patients found enjoyment from the exercise sessions aren't easily measured with the tools that we currently have available to us. One of our patients, KH, decided to collect some data on sleep herself individually and independently, and she felt that she wanted to share that with us. So I'm sharing it with you here. And she also emailed me to give me an information a little bit of information, about how she felt the project was going on her perspective. So she's talked about managing 3 weeks at the gym, how she's doing between 2.5 to 2.5 hours a week with some additional home exercise, which is fantastic. She's really enjoying it. She really had a positive relationship with her PT, and that was very encouraging. She used a watch, I think, to be able to measure her sleep quality. And you can see from the graphs that this kind of improved as we see going up. As the more activity she did, the better her sleep improved. And over a longer time period, we can see the general trend is that her sleep quality improved over several months, which is all very encouraging. And just a snapshot, just an aside to the whole project, which I felt was important to share, because even though we look at specifics, the outcomes that we're interested in may not be the outcomes that the patients are interested in. And this person particularly felt that her sleep was enhanced and improved using exercise as an intervention. There were, however, some pitfalls. We did experience some difficulty establishing complementary access to the gyms that we used. Our centre is a regional centre and spans a large geographical area, which meant liaising with different government and government health facilities was required, so more than one. So you had to explore how to access different regional exercise facilities and try to get people on board to promote exercise in the lives of people with ill health. So it was challenging, and it took some time initially, but thereafter we've seemed to have smoothed the path for continuing to enable complementary access for some time periods at some of the gyms in our local areas, which is good. Motivation of both the student and the person with cystic fibrosis was occasionally quite a challenge, and particularly difficult over the 26-week period. We felt that potentially 26 weeks was a long time to ensure that both student and person with cystic fibrosis were motivated to continue with the project, considering that they have holidays and other life commitments to build into that time period. On occasion, access to the exercise equipment was limited because we were only enabled to use the facilities 1 day per week. So if it was difficult timetabling the patients with CF, then we weren't able to do all those. And also we felt that sometimes if the equipment was being maintained, it was unavailable for us to use. Again, the duration of the project was somewhat too long, as this frequently led to the dropouts, and we felt therefore that we felt that following up with the patients was inappropriate, and we did not do any further follow-up analysis because we felt that 26 weeks was also too long, and we didn't know how best to approach the follow-up. However, ending on a positive note, we felt that people with CF had the opportunity to exercise in environments they previously lacked confidence in. That positively impacted on their physical and mental well-being, with continued engagement for many in physical activity where that had been previously lacking. As I said, we managed to liaise with the local government leisure facilities, and sometimes we are still able to offer complementary access to people with cystic fibrosis, although not generally during a pandemic. We've also seen that this has offered us an opportunity for ongoing personal training with people with CF who've expressed an interest, and we can use either one-to-one or group exercise online now, which has been particularly useful during the pandemic. I think we've seen, using the activity platform Beam, that we can do online exercise and we can do online group exercise, and that seems to be a real positive for our people with CF, because they have peer support and can work in an environment that, again, they hadn't been able to access previously. It gives them confidence, and now if they want to, they know how to exercise in a gym, both as a consequence of this project and everything we've done subsequently in the hospital. However, that said, I think the changing landscape of cystic fibrosis, given the benefits of the highly effective modulators in the majority of our patients, has meant that people with CF perhaps want to exercise more than they want to do their airway clearance. And we really, as clinicians, need to adapt the way we work and perhaps use other exercise health professionals to enable us to offer the best physical exercise and opportunity that we can for people with CF. So we need to promote exercise habits, and we need to consider whether other exercise professionals are better suited to deliver that. So that needs to be further explored. So I take this opportunity to thank those, particularly in the project team, particularly the West of Scotland Adult CF Unit patients, the students attending Kelvin College Glasgow, and the project team. And not forgetting the sponsors, Dr. Keith Brownlee from the Cystic Fibrosis Trust, because without them we would have had no funding to facilitate this. Thank you very much for your attention, and I'll take questions later.
We're live.
Wonderful. Okay. Thank you, Lisa, so much for that. That really inspiring. 3 years and 26 weeks with each of the patients. That really had a lot of dedication put into it. So thank you for sharing that with us. We have had a lot of questions rolling in as your presentation was going on. What I'm going to try to do is group them a little bit. We've got a bunch that are about your methodology and then a bunch that are more about your outcomes and conclusions. So I'm going to see if I can get them organized as we go. But speaking a little bit about the methodology, someone was asking that since you only had about 10 patients per year, was that because there wasn't enough interest, or was that based more on the students and the availability of the trainers?
Yeah, the first year there was, I think, 13 students in the class. So we did have 13 in the first year, and then subsequently the second year was only 9 students. So it averaged out over the 3-year period about 10 each. Sometimes we had to group students if there was too many. We felt that a couple of students could work together. We were kind of guided a little bit by the tutor at the college. If she felt that some students needed more support or were a little bit reticent to be involved highly in the project, that they maybe needed a little bit of support, so sometimes they paired up. So the 10 we just felt was a rounded number that could accommodate 10 students or 10 or 12 students each year based on the previous year or how many students were actually in the class.
Okay, that makes sense. When it comes down to actually recruiting the people with cystic fibrosis, did you have any exclusion criteria based on their medical status?
We did to a degree. We didn't have any people with Mycobacterium abscessus included, because that would have made things like CPET testing a little bit more challenging, because obviously we only have one piece of equipment and we tend to be quite rigorous in our cleaning of our equipment. We didn't have anybody that was pregnant or pre-transplant involved at the time, but apart from that, it didn't matter what your lung function was. We did try to accommodate you. So we did have some people with lung function less than 40% predicted and able to participate in the study.
Okay, wonderful. Then along those same lines, how did you guys ensure the safety of the people with CF when they were working with the students?
So we had the workshop that the students all attended. We had close liaison with all the patients, so they could contact me at any time. They had direct communication with me. The students had direct communication with their tutor, and myself and the tutor were in communication with each other. So there were a couple of occasions where we were able to go to the gyms, whether that be at the university where the students were, or at the local gyms, and help with the students there and make sure that they were safe. So it seemed to be very good. The thing is, I mean, all our patients are adults, so they actively, willingly participated. And if they had any issue, they were able to speak up for themselves or use us as a liaison to be able to sort out any problems that they had. There was a couple of times where they hadn't heard from the students and they would contact me and say, I've not heard from my PT. Is there a problem? Can you help me out? And so we would sort out any problems that they had. But they were adults, and they did take on some responsibility for their own health and well-being, but safety was always paramount for us, and we did ensure that everything went smoothly. There was no adverse events, nothing occurred as a consequence of them participating.
Okay, yeah, good. And it sounded like your long-term goal was for them to be able to exercise independently. Because another question is, did you use a model similar to outpatient pulmonary rehab?
Our pulmonary rehab classes that we have in our hospital are primarily focused for people with COPD. And I feel from a younger perspective, or a younger CF person perspective, that they're not hard enough. So if I was doing a one-to-one session with a patient with cystic fibrosis, it would be quite a challenging program, and I think the pulmonary rehab classes are perhaps not fit for that purpose as they stand at the moment. So they didn't really follow that. They kind of were definitely tailored to the individual. So if you were to see, for example, a video of a person participating with their PT, the PT kind of found out what interested the individual with CF. So for example, if it was boxing, they did a bit of boxercise. If it was running, they did a bit of running. They may go into the swimming pool if that was appropriate for them. So it was different things for different people. There was not one structured approach. It was not a standardized intervention from that perspective.
Okay, so yeah, a little bit more personalized than pulmonary rehab would have been. Okay, do you have any other, I know you guys chose the students, do you guys have any other exercise professionals at your facility, like an exercise physiologist or any other resources like that that could have been considered?
We have our exercise physiologists are the ones that do the CPET testing, so they don't deliver the exercise for us. So the only other people apart from ourselves that do exercise delivery would be the support workers, so the physio assistants. And we didn't then have one attached to our unit. We did for the last year. We had some funding available, and we were able to recruit a person to do that. So we did have an additional exercise professional then, but we didn't have at the time. So the only people available to help us do something like this would be other physiotherapists or external people.
Okay. Well, then moving on a little bit to some more of the outcomes. In terms of your outcome measure, did you consider using anything to measure improvements in strength?
We had originally looked to do the grip strength thing, but we didn't have access to equipment for that. So it was a fleeting thought, and we didn't actually know is the short answer. No, we didn't do anything with strength.
Okay. And then somebody else said that while it's certainly disappointing that there was no improvement in the exercise capacity, do you have any insight into why? Like, were there any of the people with CF that did respond and some that didn't, and any just personal thoughts on it?
Yeah, there was definitely on the data, the raw data, there was definitely a few people that did have an improvement in work rate and a few people that improved their VO2 max. So there were clear improvements, but when you look at the group as a whole, there was definitely, when you level out the playing field, as it were, there was no statistical difference. But there was definitely some people that had gained from the exercise opportunities. Even a couple of people, there's one particular person who the consultant that analysed the data said, it's a real shame that the VO2 max didn't go up because the work rate went up really well. So he really tried quite hard. So there was clear subjective issues, and some parts of the data did suggest that there was an improvement, but not all of them did.
Okay. A question just came in real quick about patients being on Trikafta. Were most of them on Trikafta?
None of them were in Trikafta.
No.
We didn't have it. It was completed in 2017. So no, we didn't have access to any of the modulator therapies then. There might have been, I'm trying to think of the patients that were involved. We had Kaleido from 2012, but nobody on the program had access to any CF modulator, so all non-modulator. In fact, it's quite an interesting point because some of them actually are on modulator therapies now. We were able to introduce Trikafta last August in the UK, in Scotland. It's different in different parts of the UK. So in Scotland last August, most of our patients in our unit are able to access that now. And a couple of the patients that were involved in the study are on Trikafta now. So it would be interesting to look at their CPET now and evaluate it compared to them. But obviously we're in the middle of a pandemic still, and we've not been able to use the CPETs. But I think that would be something to look at when we're able to use the CPETs again and evaluate the change in those patients that were measured with the CPET during our study there and what they're like now following the Trikafta.
Okay. Well, great. Thank you, Lisa, so much. I know, guys, there was a couple questions that we weren't able to get to them all. But we have got to move on to our next presentation. So thank you, Lisa, so much for taking the time to, I lost my Zoom, to chat with us.
Thank you.
So you're welcome. Our next presentation is going to be from Brooke Quitermis. She's a fourth-year medical student at the Medical College of Georgia, and she's going to be talking to us about interpreting the impact of HbA1c and tissue oxygen utilization and ventilator parameters during exercise with people living with CF.
Good morning. My name is Brooke Pace-Patermas, and I'm a fourth-year medical student at the Medical College of Georgia in Augusta, Georgia. I've also had the privilege of working with Dr. Ryan Harris and his team at the Laboratory of Integrative Vascular and Exercise Physiology, or the LIVE-P, for the past 5 years. Today, I'll be presenting on our work regarding tissue oxygen utilization and ventilatory parameters during exercise in people with cystic fibrosis and the role of HbA1c in this process. And I have no relationships to discuss related to this presentation. So CF truly is a systemic disease. It's classically characterized by pulmonary dysfunction, pancreatic insufficiency, exercise intolerance, and various other abnormalities. I want to take a few moments to discuss exercise capacity and cystic fibrosis. The degree of exercise intolerance can predict disease-associated morbidity and mortality in individuals with CF. It's not unreasonable to assume that exercise intolerance in CF is largely related to impaired lung function. However, studies, including those performed in our own lab, have shown that exercise intolerance in CF occurs independent of lung function. We've shown that endothelial and microvascular dysfunction, which is present in CF, also contribute to decreased exercise capacity in this population. Exercise capacity is typically measured by VO2 max, which is the maximal amount of oxygen that an individual can utilize during exercise. Aerobic exercise capacity can be determined by evaluating VO2 at ventilatory threshold, also known as VT. It's important to evaluate aerobic exercise because this time an individual is exclusively using oxygen for production of cellular energy. VT is going to occur just prior to when ventilation starts increasing disproportionately to VO2, which suggests the body is no longer using oxygen efficiently to produce energy. The intersection between the two lines on the graph shown here shows that this is a point at which VT occurs. Next, we'll discuss ventilatory parameters during exercise in CF. The slope of a minute ventilation over volume of exhaled carbon dioxide slope is expressed as VE over VCO2. This is a measure of how efficiently the body can clear carbon dioxide from the lungs. The slope of this line is predictive of mortality in various populations, most notably in patients with congestive heart failure, with higher values correlating to an increased risk of mortality. The figure shown here shows a healthy patient in graph A and a patient with congestive heart failure in graph B. The slope of the line in graph B is much steeper than that of graph A, indicating an increased risk of mortality in patient B compared with patient A. In regards to people with CF, our lab has demonstrated that people with CF exhibit both an impairment in oxygen uptake kinetics during exercise and an increase in minute ventilation over VCO2 slope over time without a corresponding decrease in exercise capacity. Pancreatic insufficiency is the most common extrapulmonary abnormality in CF. Thick mucus secretions block ducts in the pancreas, leading to loss of exocrine function, and this fibrosis that results can also lead to progressive endocrine dysfunction. So about 50% of adults with CF develop cystic fibrosis-related diabetes, or CFRD. In addition, decreased insulin production from the pancreas paired with impaired glucose uptake from skeletal muscle leads to elevated blood glucose and therefore elevated HbA1c in some individuals with CF. HbA1c is traditionally used to diagnose and monitor type 2 diabetes, but its use in the monitoring and diagnosis of CFRD is controversial. Individuals with CF are thought to have a decreased red blood cell lifespan, and this idea has traditionally contributed to hesitance in using HbA1c as a tool to diagnose CFRD. A 2-hour oral glucose tolerance test, also known as an OGTT, is currently the gold standard to diagnose CFRD. However, this test is very time-consuming and is often very unpleasant to patients. A 2016 study published in the Journal of Cystic Fibrosis showed that HbA1c of greater than or equal to 5.8% is effective in diagnosing CFRD. The graph shown on this slide is representative of over 300 patients who participated in this study. The dashed horizontal line represents HbA1c of greater than or equal to 5.8%, and the vertical line represents an OGTT 2-hour diabetes threshold of 11.1 millimoles per liter. As shown in this figure, the vast majority of individuals with an OGTT diagnostic of CFRD also had an HbA1c of greater than or equal to 5.8%. And this was statistically significant with a p-value of 0.01. So we know that individuals with CF have impaired glucose tolerance. We also know they have impaired exercise capacity and impaired ventilatory parameters during exercise. We know that glycemic control is impaired in CF and that HbA1c can be used to monitor a level of glycemic control among these patients. It's therefore plausible that glycosylated hemoglobin can negatively impact the utilization of oxygen by the working tissue during exercise, as well as CO2 removal by the lungs in people with CF. So to test this hypothesis, we had 17 people with CF complete an experimental visit at the live peak. We performed fasting blood work on these participants to determine their hemoglobin levels and their HbA1c. And we also performed a pulmonary function test, or PFT, in accordance with guidelines established by the American Thoracic Society. Indices of exercise capacity and ventilatory parameters were determined from expired gases during a maximal exercise test using the Godfrey protocol on a cycloergometer. A NIRS device, which is shown here, is also placed on the vastus lateralis, and this allows us to determine the state of hemoglobin at different points during exercise. So NIRS, or near-infrared spectroscopy, is a useful tool because near-infrared light penetrates biologic tissues. Hemoglobin and myoglobin are both chromophores, which are going to absorb light at different frequencies depending on if they're in an oxygenated or a deoxygenated state. So NIRS is able to detect these differences, and data can be analyzed to determine concentration of oxygenated versus deoxygenated hemoglobin at different points during the exercise test. This graph on the slide is from a cerebral perfusion study and essentially just shows that hemoglobin and oxygenated hemoglobin are gonna absorb this light differently. So now we move on to our results. So this table shows the characteristics of our patient population. We also divided our population into groups by A1C according to the threshold established in the paper that we had mentioned earlier. Patients in the low HbA1c group had an A1C of less than or equal to 5.7%, while those in the high A1C group had an A1C of greater than 5.7%. There were more males than females in the low A1C group and more females than males in the high A1C group. There were no differences between age, BMI, and minute ventilation between the two groups. There was a difference in FEV1 between the two groups, as well as hemoglobin levels, but these were largely contributed to sex differences due to the differences in sex between the two groups. Therefore, we controlled for sex as well as percent predicted lung function in our subsequent analyses. So our studies show that exercise capacity, ventilatory parameters, and tissue oxygenation are different in patients with low A1C versus high A1C. So this first figure shows that VO2 peak was significantly higher in individuals with the lower A1C. We also see that VO2 at ventilatory threshold was significantly higher in the low HbA1c group versus a high HbA1c group. The minute ventilation over VCO2 slope was higher in the high A1C group than the low A1C group, but there was no change in minute ventilation between the two groups. Therefore, end-tidal CO2 was significantly lower in the high A1C group versus a low A1C group. Lastly, in a subset of patients with NIRS data, patients in the high HbA1c group had a lower concentration of deoxygenated hemoglobin at the vastus lateralis at ventilatory threshold than those in the low HbA1c group, indicating that there is impaired release of oxygen from the hemoglobin molecule during aerobic exercise in patients in the high HbA1c group. The correlations shown on this slide further emphasize our claim that exercise capacity, ventilatory parameters, and tissue oxygenation are associated with HbA1c. VO2 peak, end-tidal CO2, and deoxygenated hemoglobin at ventilatory threshold are negatively correlated with HbA1c, while minute ventilation over VCO2 slope was positively correlated with HbA1c. So in conclusion, among people with CF, HbA1c is negatively associated with VO2 max as well as VO2 at VT. HbA1c is also positively associated with minute ventilation over VCO2 slope, but it is not associated with ventilation. Subsequently, individuals in the high HbA1c group had a lower end-tidal CO2 during exercise than those in the low HbA1c group. And lastly, HbA1c is negatively associated with concentration of deoxygenated hemoglobin at the working tissue during ventilatory threshold during an exercise test. So this graphic illustrates the clinical implications of these findings. Elevated HbA1c is related to changes in ventilatory parameters and muscle oxygenation during exercise. This, combined with endothelial dysfunction, microvascular dysfunction, impaired lung function, and decreased muscle mass, all contribute to a decline in aerobic exercise capacity in this patient population. These are the sources that I used to create this presentation. Thank you all for your attention today. This study was supported by the Laboratory of Integrative Vascular and Exercise Physiology, or the LIVP, and our founder and director is Dr. Ryan Harris. At this time, I welcome any questions that any of you have. Thank you very much.
Okay, thank you, Brooke, so much for that. We've got a couple of questions already rolling in for you. So I think the first one that came through is, do you have any physical activity data? It seems as though a person who's more physically active may have a lower HbA1c and maybe a better exercise capacity.
I think that's a really good point. And it's definitely something that we talk to our patients about informally prior to starting, but it's not something that we look at as a means of a study variable in this. Are you able to hear me?
I think it's my internet. I think it's my internet connection. I could hear you a little bit.
Okay, I'll just repeat what I said.
Okay.
Yeah, I can hear you. So I'll just repeat what I said. I think that's a really good point to bring up, and it's definitely something that we talk about informally to our patients, but it's not something that we look at in terms of an exercise variable.
Okay, sounds good. Sorry, I'm going to turn off my video and see if that helps with my internet connection. But okay, thanks, Brooke. Also, another one, exciting research. Based on your data, do you think that an intervention to improve the HbA1c would result in an increase in someone's exercise capacity?
So that's definitely what we're thinking about going forward, seeing that if we are able to improve their level of glycemic control, if that would help, but that's something that further studies would have to confirm for us.
Okay, and along that note, somebody mentioned that HbA1c, while it's not the best indicator of glycemic control in people with CF, do you have any suggestions on what else may be used?
So kind of what we mentioned earlier about how an oral glucose tolerance test is the gold standard right now, that's definitely something that can be used to measure, to get a better idea of glycemic control. And that's especially when you're looking at people that do not qualify yet for CFRD to determine kind of their exact level of that. And that is something that could be used, but that is a very time consuming test. And so this study was really trying to look at this one level that's very easy to obtain and seeing if that is correlated with a known marker of morbidity and mortality in this patient population.
Okay. Were any of the patients, was there any difference, or were any of the patients on modulators?
That's a great question. So similar to what Lisa was saying, a lot of this data was conducted prior to 2019 when Trikafta was released. So some of our patients that were in later studies were, but the vast majority were not.
Okay. Okay. And then were any of the patients in the high HbA1c group taking insulin?
Yes, there were a few that were taking insulin that were in the high A1C
Okay. And then
because they
does,
had an established diagnosis of CFRD.
gotcha. Okay. And then would insulin impact the oxygen carrying capacity at all?
So that's a very interesting question, and it's something that we would like to look at later to see if it's something that has to do with the actual hemoglobin molecule itself versus that impact with insulin supplementation.
Okay, great. Then there is some evidence out there that exercise training can help improve glycemic control. So can exercise training modulate HbA1c as well as HbA1c modulating the ability to train?
That is a very interesting question. And I think a lot of this is just going to have to come from speculation from what I've known about our patients and about the mechanism of this disease. But I think it's entirely possible that because exercise does, increase GLUT4 and the ability for cells to take glucose into them to use for energy, I think that it definitely could modulate. We don't have any data on that at this time.
Okay. I think we have come to the end of our time with you, Brooke. Thank you so much for your presentation and sharing all that really interesting research with us. Okay, and we're going to move on. Next, we have Tom Tobin, who is a physiotherapist at the Royal Brompton Hospital in London, England. And he is going to be talking to us about the feasibility and the safety of virtual oxygen assessment in people living with cystic fibrosis.
Good afternoon. My name is Tom Tobin, and I'm a specialist physiotherapist at the Royal Brompton Hospital in London, United Kingdom, working with adults with cystic fibrosis. Just to say that there are no relationships to disclose related to this presentation. So the aim of my project and the aim of this presentation is to assess the feasibility of virtual ambulatory oxygen assessments in the CF population at the Royal Brompton. As we know, we've been in the midst of a global pandemic for coming up to 2 years now. And as such, virtual solutions to assessments and patient monitoring have been expedited and have been paramount to maintaining contact with our patients, most of whom in the CF population are in the highly vulnerable category, so therefore have been shielding during the first and second waves in the UK. If we add to this that the EMA approved Kaftrio, or Trikafta as it's known in the US, for patients with CF with delta F508, homozygous or heterozygous with a minimal function on the other allele. This has meant that a lot of our patients in our clinic have had improved health status. So as a result, lots of people who have been using ambulatory oxygen have felt that they no longer need to use it, and people have been voting with their feet and have stopped using it, which is a bit of a worry when we haven't got any objective measures of whether this is correct or whether actually, in fact, although they feel better, they still desaturate on exercise or ambulation and require supplementary oxygen to maintain saturations above 90%. So therefore, we needed to come up with an idea or a solution to this, that whilst they couldn't come to the clinic face to face, where we could get an objective measure of their saturations on ambulation, to ensure that oxygen therapy was prescribed appropriately. And the BTS guidelines do suggest that people with ambulatory oxygen have their oxygen requirements reviewed 6 monthly. So this project aimed to find a way of kind of meeting that criteria as well. So patients with CF who were deemed to require a review of their oxygen demands were highlighted by either a physiotherapist or a part of the medical team, one of the doctors, during their virtual clinic appointments. And if they were deemed appropriate, then we were contacting them to arrange a suitable time and date to do this virtual assessment. If patients didn't have their own pulse oximeter, We were sending them out in the post prior to the appointment, so they had all of the equipment they needed to be able to do an assessment of their oxygen requirements safely at home. So, as I said, we arranged a video call for a time and date that suited the patient, making sure that an accompanying adult was at the property in case of any adverse events. We also did a full subjective history prior to doing the assessment to ensure that they were well enough and there was no contraindications to us doing an exercise test. In particular, we paid attention to people with cystic fibrosis related diabetes, asking them to check their blood glucose levels prior to the assessment and having a sugary snack on hand in the event that they did feel like their sugars were dropping. The 6-minute walk test is the gold standard for measuring people's ambulatory oxygen requirements. But unfortunately, due to space constraints in people's properties, not many people had the space to have a 10-meter track that was clear of kind of obstacles to be able to do the test. So therefore, we had to think of an alternative way of eliciting exertional desaturation that could be done in a small space with minimal equipment. I reached out to other CF centres in the UK and also had a little look through the research, the literature, but there is no kind of alternative test. The 6-minute walk test is seen as the gold standard, so therefore no other tests have really been researched. So I came up with a 3-minute step test from just perusing the literature as a viable option, and we tried it with some inpatient CF patients that we had at the time, and it did seem to elicit exertional desaturation to the same extent as a 6-minute walk test did. So therefore, we thought that we would pilot it and just see whether it was an appropriate and a feasible test to use. As I said, we sent out oxygen oximeters to our patients who didn't have them already, and the patients would self-report their heart rate, their saturations, and also their breathlessness using the Borg dyspnea scale. We then used the findings of our assessment to guide our oxygen prescription and discuss that with the patient. So the demographics of the patients, I won't read through this, but it was kind of indicative of our cohort of patients that use ambulatory oxygen. Just of note, the FEV1 around 38.5%. So it's people with more severe lung disease, which we would expect, but not people with kind of sub 20% FEV1s that potentially doing a virtual oxygen assessment would not be appropriate and maybe kind of more risky than this cohort that we used. Moving on to the results of this pilot study. So we had 10 participants that agreed to do a virtual oxygen assessment. Of these 10, 9 already had oxygen in place and 1 patient did not, but had noticed that they were desaturating on walking around. So therefore we guesstimated a flow rate and prescribed that, so the oxygen equipment was in situ prior to the assessment, and then we could use that to assess whether it made a difference to their desaturation on exertion. The test that was completed, so the 6-minute walk test was completed in 1 patient who had a large enough space to do that. The 3-minute step test was done in 8 patients. And we also did 1 assessment using a patient's home exercise plan. So this particular patient would only use oxygen on more intense exercise and had noticed that they were desaturating more than previously. So therefore we did a home exercise routine with them, their normal workout, but with us monitoring their saturations and breathlessness. And the outcome of these 10 reviews, the O2 was removed in 2 of these patients. So their understanding that they felt better and they didn't need it anymore was correct. In 2 of the patients, their oxygen levels, their oxygen requirements, were unchanged. and then oxygen was changed in 60% of cases, with free being decreased. So again, patients feeling more well on the triple therapy, and in free cases, the oxygen actually being increased. Of note, all 10 patients were on triple therapy. The increase in oxygen requirements did interest me, and I think that looking back, the people that this affected, and this was the case for, had previously done 6-minute walk tests where they hadn't completed many laps of the 30-meter track. So therefore, the 3-minute step test, they actually were able to work a lot harder for a lot longer, for the whole 3 minutes. So therefore, got more of a physiological response to exercise. So therefore, working at a higher intensity and needed more oxygen to support that. But it may just also show that for some people with severe lung disease and structural changes, that despite triple therapy and feeling better and more stability, not everyone will get the same results or improvements in terms of oxygenation or sputum load. So adverse events, there were no serious adverse events during any of the assessments, which is good. That was the main aim of this study, was to show that this was safe and feasible to do. 2 of the 3-minute step tests were ended prematurely at patient request due to breathlessness. But this is the case with 6-minute walk test. Patients can self-terminate at any point, and both of these patients returned to baseline observations within 3 minutes. So obviously with us still on the video call and monitoring their condition. So just to discuss some points from this pilot study, the optimization of oxygen therapy was able to be maintained during a global pandemic, which is reassuring. Like I said, lots of people were making their own decisions around their oxygen therapy, which, based on the results of these assessments, were not always what was actually happening physiologically. 10 virtual assessments were completed within 3 months, so there was definitely a demand for this service. And the study suggests that the 3-minute step test is easy to conduct and does demonstrate exertional desaturation. So although it's not validated, in our experience, it is a good test to alleviate, to demonstrate exertional desaturation if it is present in our patient cohort. The main reason why the 3-minute step test was used was because of space constraints. So if we could, we would use the gold standard of the 6-minute walk test. But as I already alluded to in the earlier slides, it's not practical in most accommodations, especially in central London. So to conclude, virtual oxygen assessments were safe. We didn't have any adverse effects, and patients felt comfortable doing this. And as I already mentioned, we had an accompanying adult available in case patients did not feel well whilst completing the assessment. Further research into the validity and the sensitivity of the 3-minute step test as a tool for monitoring exertional desaturation is needed. You could argue that with the return of face-to-face clinics, then we can revert back to doing our 6-minute walk tests. However, we have found that the model of CF care moving forwards will definitely still contain a virtual element. Lots of patients struggle to come into the hospital for their clinic appointments. It's expensive. They spend a lot of time traveling into central London. They have to get on public transport, and lots of people are feeling uncomfortable about that at the moment. And also we noticed that patients would become ill following a clinic appointment because they would have spent the whole day traveling and having the clinic appointment. So therefore were unable to do their usual treatments to maintain their health and well-being. And there's also the argument that this could be used in other disease groups. It doesn't have to be limited to cystic fibrosis. Lots of our other teams within the hospital, non-CF bronchiectasis, asthma, COPD, have also found virtual solutions to their clinic appointments. So if they have patients that they need to review their oxygen requirements, or are concerned that their oxygen prescription might be outdated or incorrect, then this could be a potential solution to that as well. And I'll be interested in the questions after this presentation to hear other people's experiences, and if other people are doing around the world, if other people are doing similar virtual solutions, or would think to implement this sort of clinic review. Thank you for your time.
Great. Thanks, Tom. That was really interesting. That really very different than other projects that we've seen around. So thank you for presenting on that and sharing your experience.
No problem.
I don't know if you're surprised by this, but you're getting a lot of questions roll in about how much you trust and the reliability of the pulse oximeters. So let me dig into those a little bit. Sure. One question that was coming through is, did you have any concern about the fact that there was variability in the different pulse ox devices that were being used?
It's a good question, and I suppose if we were doing this for a kind of scientific study and we wanted everything to be kind of the same and objectively measured, then you could argue that you'd want uniformity. But in our case, the pulse oximeters that we use, when we would do a 6-minute walk test, we'd use the same portable ones that we sent out to patients. So actually, from doing it at home versus doing it in the clinic, there was no difference. And we do go on what our patients kind of say. If they've got their own pulse oximeter, we will kind of use their data. Obviously, if we were getting kind of crazy results and saturations that didn't seem like they fitted with the picture, then that might have been something that we could look into further and maybe not make kind of medical decisions based on that. But we found that the traces were really good on the ones that we used, and they were giving kind of reliable results kind of throughout the assessment.
Okay. You pre-answered some of the questions that were coming up a little bit later, including sometimes the pulse oximeters work well at rest, and then when you get somebody up and exercising and moving around, they don't work as well. It sounds like that was not your experience, that you guys were getting a good signal even with the exercise.
Yeah, so the ones that we were using have the kind of the trace on them, and we were getting an uninterrupted trace. Don't get me wrong, I've definitely experienced it where we've got really good sats at sitting, and then as soon as you even just stand up, it all goes to pot. So it's definitely something to think about. But we do use that in the clinical setting, because using like a Dynamap or a kind of fixed OBS machine with a 6-minute walk test also has its own kind of barriers of kind of dragging it along with them if you want to keep it on for constant monitoring. So yeah, I think it's the lesser of two evils, really.
Okay, and to clarify, so these are the same pulse oximeters you guys would have been using in clinic anyway?
Yes, yeah.
Okay, there we go. That answers a bunch of these questions. So watching the signal. How about people are asking who paid for or provided the oximeters?
Yeah, so we, in the UK, there was the NHS England provided a COVID fund. So it was money that was given to hospitals to optimize services or deliver alternative services during the COVID period. So the CF Centre got some money that we could use for kind of anything we felt necessary to kind of maintain our patient kind of experience, even in the absence of face-to-face clinics. So yeah, we got that money from the NHS, which was great.
Yeah, that is great. Okay. A little bit more about the pulse oxes. Some people feel that if they've been compared to the like Dynamaps or other things, the pulse oxes tend to be lower. Has that been your experience, and did you take that into consideration, or do you find them pretty similar?
Yeah, so this is only going on my personal experience, because I haven't done any kind of studies into it, and I don't want to mislead anyone. But it always takes me back to a patient I had who was really fixed on numbers. So he had 3 pulse oximeters from different companies, and he wore them on different fingers and was very fixed on making sure they were all the same. And he used to get good results with that. I find that, yeah, often you can get kind of a couple of percentage points discrepancy, but I suppose that does make a difference when we're looking at oxygen prescription. But when you're looking at kind of the overall trend, I feel you can still use it it's never going to be perfect, and it's not going to be the ideal solution. But I feel like it gives you an idea of what's going on, especially when, like I said in the presentation, our patients were stopping using the oxygen on their own and just saying, no, I feel good. And we were, slightly anxious about that.
Yeah, no, you're right. Okay. A question about what height step were you using with the patients?
Yes. So what we were using is the first step of their stair. So again, if we're going into my methodology, like, don't shoot me. So they're not going to be exactly the same height, and we weren't taking into account kind of how many steps they completed or anything like that. It was literally just a method of kind of getting an exertional desaturation or an exertional physiological response. So we didn't kind of clarify or stipulate what height the step needed to be. We do, as an exercise test, to look at submaximal VO2 max testing, or VO2 testing, sorry. We do the Chester step test, where kind of the heights are regimented and it's all very much more fixed. But for this 3-minute step test, we were just doing whatever step that they had available at home, whether that be kind of their doorstep or the first step of their stairs going up to the second floor.
And I think a good question leading right into what you're talking about right now is that if the goal was just to determine oxygen use or exertional oxygen use, do you feel like a more submaximal test would have been more useful to more mimic regular activity during the day versus exercise?
Yeah, so I suppose you could argue that the 3-minute step test is submaximal as its patient. I'm not giving them any, but you must do as many steps as you can in this time period. It's a steady rate, how you would normally go up the stairs, and continue for as long as possible. So, you could argue that it is sub-maximal. We did do, like I alluded to in the presentation, someone doing their own exercise program as well. So we are trying to make it as patient-specific as possible, because some of our patients don't need oxygen for ambulation. They can walk around and maintain their saturations just fine. But when they kind of get on the treadmill and start running a 5K, or they're doing their weights and stuff like that, then they do notice that they struggle a little bit more. So I think submaximal in this cohort is definitely the better way of monitoring SpO2.
Okay. In the last 30 seconds, how long did it take you to complete these virtual appointments?
Yeah, so it varied based on people's technical skills, I suppose, the patients. But we'd hope to have it all done in half an hour. So by the time you've connected it, the actual test takes 3 minutes. Obviously, you've got your subjective assessment to start with, the time afterwards for recovery, and then the discussion about kind of what the results mean and what we're going to do moving forwards. But the aim was for it to be a 30-minute appointment. Not always did it fit into 30 minutes, but.
Okay, great. Thank you, Tom, very much for sharing all that with us.
No problem. Thank you.
Okay, and our last abstract presentation that we have is Joel Murmis, and he's going to discuss the feasibility of a telehealth-based exercise training for adults with cystic fibrosis.
Hi, my name is Joel Murmis, and on behalf of our research team at the University of Kansas Medical Center, I'm delighted to present our project, Feasibility of a Telehealth-Based Aerobic Exercise Training Program for Adults with Cystic Fibrosis. I have nothing to disclose. When discussing any therapy or intervention to improve outcomes in CF, we need to first reflect on how far we've come and how advances in the treatment are rapidly changing our approach to care for people with CF. Dorothy Anderson first described the disease in 1939, and the CF gene was then identified in 1989. And now, just over 30 years later, remarkably, near 90% of adults with CF in the United States are on highly effective modulator therapy. As we can see here, lung function in 2019 was already improving to where the majority of 18-year-olds with CF had normal or near normal lung function. And this data comes to us prior to the approval of elexacaftor, tezacaftor, and ivacaftor in 2019. So as a result, we're going to see a significant increase in the population of adults living with cystic fibrosis. While the improvement in outcomes is an amazing accomplishment, in our clinic, we are observing some unexpected health developments in people on highly effective modulator therapy. As shown here, prior to 2019, we were already seeing an average BMI increasing into the normal range. And for individuals who for decades were prescribed high-calorie diets, or for some to eat whatever they wanted to maintain their weight, modulators for many has been a game changer. Many people with CF are now being asked to suddenly change decades of eating habits as they are now able to, readily gain weight. In a single CF Center report in 2020 in the United States CF Center, 25% of adults with severe disease-causing mutations were overweight or obese. A snapshot of our BMI at our center just a few months ago indicated about 30% of our center is now either overweight or obese. And we have to wonder what the health implications of this may be, knowing that 30 to 40% of these adults have CF-related diabetes. The risk for development of metabolic syndrome and the potential impact on CF-related diabetes outcomes, raises concern, but at this point is unknown. Additionally, what impact could weight gain and related metabolic syndrome have on CF liver disease such as steatosis or fatty liver disease? Historically, CF liver disease was predominantly diagnosed in pediatric age patients. However, this UK group demonstrated the impact of an older population on CF liver disease, as they found that the majority of patients with a new diagnosis of cirrhosis over this 6-year follow-up period were adults. And while highly effective modulator therapy has resulted in marked improvements for most of people with CF, if we extrapolate from the GOAL study, the study of people with G551D mutation on ivacaftor, where we see similar sweat chloride levels below the diagnostic cutoff of 60 to what we see for many people on elexacaftor, tezacaftor, and ivacaftor. Unfortunately, we still see gradual lung function decline as seen here over the 5.5-year follow-up period. So while respiratory symptoms are remarkably improved overall, unfortunately, it is still expected that for many people on highly effective modulator therapy, lung function is likely to gradually decline over time. Historically, we know that it is typical for people to overreport how much airway clearance they're actually doing, as shown by this study. And it has been our experience that as patients in our clinic are feeling so much better, many are understandably stopping their routine CF inhaled therapies and airway clearance, as they really just don't notice a difference on a day-to-day basis in how they're feeling, even if they do their airway clearance. So while outcomes in CF have dramatically improved, we really have a new paradigm of care in CF. How do our treatment teams continue to support people with CF to make sure the improvements in health outcomes continue? Now, we believe the answer is exercise. Exercise has the potential to prevent or reduce the risks of metabolic syndrome by improving insulin sensitivity and minimizing risk of liver steatosis. Additionally, exercise has the added benefit of supplementing and potentially even replacing airway clearance for some. Traditional airway clearance does not have the other health benefits of exercise, and so people with CF and their providers are interested in learning more about exercise as a treatment for CF. In this survey studying 488 patients and CF care providers, more than 70% reported they would support a trial of exercise as a replacement for airway clearance. So how can we conduct an exercise trial in the midst of the pandemic? Fortunately, the marked increase in people working out from home and home workout platforms has provided us a great opportunity to conduct a home exercise program. When discussing home-based exercise, many people think of expensive home exercise equipment and that it's required. And this is not necessarily the case, as many more economical options exist, including some free web-based services such as Beam. The service shown here, which is supported by the CF Foundation and even has classes created just for people with CF. So in this study, we sought to evaluate the feasibility and uptake of personalized home exercise prescribed in the telehealth platform. We hypothesized that greater than 70% of participants in the intervention arm will adhere to more than 70% of their weekly prescribed exercise. Additionally, we hypothesized that there would be a greater improvement in exercise capacity and quality of life in participants randomized to the exercise intervention. So looking at the study design, in this study, it was a randomized controlled 12-week trial in which people with CF on highly effective modulator therapy for at least 1 month were randomized to usual care or usual care plus weekly aerobic exercise prescription via an exercise coach telehealth visit. Participants had to be cleared by their CF provider to participate. Additionally, people were excluded if they already exercised more than 150 minutes per week, if they were pregnant, post-transplant, or were oxygen dependent. Participants randomized to exercise coaching were prescribed a progressive increase in aerobic exercise minutes, starting with 60 minutes of weekly exercise during the first week, with a gradual increase to a target of 180 minutes of aerobic exercise by week 9. Exercise participants were coached to spend 1/3 of their exercise time at a vigorous aerobic exercise level. The goal with exercise prescription was not to instruct people on what type of exercise to do, but rather give the participant the freedom to choose the exercise of their choice while guiding them on intensity and duration of exercise based upon their fitness level. Patients were instructed to wear a provided Garmin Vivo Smart 4 fitness tracker during all exercise to collect exercise time and their heart rate data. Percent predicted FEV1, hemoglobin A1C, sweat chloride quality of life via the CFQR, and submaximal VO2 via cardiopulmonary exercise testing were assessed at baseline and at study completion. So looking at the results and the baseline characteristics, our target enrollment was 40 participants. Enrollment was progressing nicely with a broad patient enthusiasm. We enrolled 9 patients in just over 1 month. Unfortunately, the study was halted by our institution at the onset of the pandemic. So we are just now beginning to resume enrollment, but at present we have had 8 of 9 people complete the study. Of those completing the study, 2 were randomized to the exercise group and 6 to the usual care group. As shown with the red arrow in the demographics table, 1 participant with advanced lung disease left the study early as he was transplanted. The 2 exercise group participants shown with the green arrows were on average older with a lower baseline FEV1 compared to the usual care group. At enrollment, we assessed barriers to exercise in hopes that identifying these barriers would help our coaches better understand how to motivate participants during the telecoaching sessions. We found that lack of discipline and lack of time were identified by participants as the primary barriers to exercise. Our hope was that coaching would help with those that felt they lacked the discipline, and that a home-based approach as compared to going to the gym or a fitness center would minimize the lack of time barrier. So looking at the primary results, we hypothesized that participants randomized to the coaching group would complete greater than 70% of their weekly prescribed exercise time. This primary endpoint was met as the exercise group completed 87% of their weekly prescribed exercise time, measured by downloaded data from their activity monitors. At study completion, cardiorespiratory variables, including exercise time and work in watts, improved for both exercise participants. Looking at the results in the figure, you can see that the mean change in sweat chloride, percent predicted FEV1, hemoglobin A1C, and CFQR all trended favorably in the exercise coaching group as compared to the usual care group. Additionally, the BMI declined in the exercise group, and we consider this a favorable trend as well, given that the average BMI in the exercise group was overweight at 28. The trend toward reduction in sweat chloride with increased exercise is an interesting finding. We hypothesized that reduction in oxidative stress and inflammation secondary to exercise may be associated with improved CFTR function, as oxidative stress and pathways increasing nitric oxide have been demonstrated to regulate CFTR gene expression. In conclusion, the inferences from this small sample size are limited. However, the home-based telehealth coaching was favorable and did demonstrate improvement in important parameters linked to morbidity and mortality in CF. As mentioned above, we are now resuming enrollment with a plan to complete hyperpolarized MRI of the lung in study participants to explore with a more sensitive measure than FEV1 the impact on exercise on lung health in people with CF. This work would not be possible without the support of our entire research team, who I want to thank. I want to thank Dr. Dave Burnett, Ashley Derry, and Allison Bustos, who you can see here. And with that, I will conclude and look forward to answering any questions that you may have.
Great. Okay. Thanks, Joel. Thanks for that great presentation. Bunch of people interested in exercise and some of your results that you have coming in. So we should have a good conversation coming up.
Great.
So to get us started, I think a couple in-depth, deeper, longer questions. I'm trying to synthesize them for you. But so the two patients in the exercise group who appeared to have the increase in their HbA1c. So in support of the previous presentation we heard earlier, do you think that a change in the HbA1c contributed to your increase in their exercise capacity? Oh, so it should have been the patients that decreased their HbA1c. Do you think that that could have had any relationship to their increase in their exercise capacity?
Yeah, that's something before, I guess, the earlier presentation I hadn't really considered, but certainly, I guess, possible. I think we were overall just encouraged by the increase in their exercise tolerance and the trend that had with a number of important, biomarkers, including HbA1c, is just an overall improvement in health and insulin sensitivity. But could there be a direct correlation there? It's certainly possible, I guess.
Okay. And then along with that, you had a lot of biomarkers. You had looked at barriers prior to the start of the study. Did you collect any subjective data or any of the subjective information from the patient, from the people at the end of the study to see their thoughts on it?
Yeah, that's a good question. We did the CFQR at the end of the study, but we didn't reassess barriers. Obviously we were visiting with people weekly about and having conversations about that, which is part of the coaching program, but didn't conduct the actual barriers survey in the same way at the end. I think everyone felt that the coaching program was beneficial in holding people, helping hold people accountable and helping them remain motivated, which were two of the main barriers. So, but we didn't conduct the actual survey at the end. So,
okay. You're also getting some questions about a little bit more of the details of the coaching. So, who did the coaching? How often was the coaching happening? I guess to answer a lot of people's questions, do you mind going into a little bit more detail about the coaching program?
Yeah, absolutely. We didn't have so the coaching was done by our team dietitian and a respiratory therapist on our team at our university. And we met weekly with one of the co-investigators, Dave Burnett, who's an exercise physiologist, and talked about generalized coaching approach to coaching, but we didn't have a specific protocol per se. As far as the conversation, it was more a weekly touch base, kind of see what people needed. We would review their downloaded activity monitors, give them heart rate targets, and we did that on a weekly basis, and then answered any questions they had as far as what kind of exercise they were doing, what their plans were for the next week. And we basically did that on a weekly basis as we went along. Some people definitely needed more time than others based upon their experience with exercise in the past. So in some ways it was guided by the participant and what they needed.
Okay. And just to clarify, were the respiratory therapists and the dietitians then going back to the exercise physiologist to, you mentioned like target heart rate and adjustments like that, or were the RTs and the dietitians responsible for making those recommendations as well?
Yeah, they would go ahead and make those recommendations. Those recommendations were primarily protocol driven, with our goal to get to 1/3 of the exercise time in vigorous exercise with an escalation over the 12-week period based upon the number of minutes of exercise per week. But we would just meet as a team weekly and discuss how things were going and general strategies on those conversations with the participants.
Okay. Then another question came in, interesting that you're using the dietitians based on the fact that adiposity is in part based on diet and how important diet now is in the age of modulators. Did you collect or coach at all on any dietary or nutritional data and training?
Yeah, obviously there's a direct, relationship between exercise and diet. For this particular study, we really just focused on the exercise component. So there wasn't any specific dietary education that was part of what we planned to do. Certainly, if someone had questions, we would do our best to answer those if they had questions related to their diet. But we didn't seek to directly discuss diet with them on a weekly basis. So.
Okay. A specific question. What went into the decision of having those two professionals being the ones that were involved in the coaching?
Yeah, they're just the primary members of our team who are really interested in exercise and enthusiastic about it. And, I think for each center, the people that do the coaching could vary depending on what fits and works for your center. We have a lot more involvement with our respiratory therapy team here at KU, but other centers may have a physical therapist, obviously, who would be a great coach. So I don't know that it necessarily needs to be those two people, but they're the kind of core team members that were enthusiastic about the project and had the time allotted to do it. So.
Okay. Somebody was asking if you could talk a little bit more about the Xenon MRI.
Yeah, sure. So we're particularly interested in, trying to convince patients, people with CF, of the importance of exercise. If you look at, and we saw that with one of the earlier projects, if you look at exercise over a shorter period of time, my concern is that it's going to be difficult, I think, to find differences in FEV1 over time, because people, particularly for people on modulators now who are so healthy, who are likely to have a stable FEV1, despite adherence with their treatments and exercise. Xenon MRI has been demonstrated to be a more sensitive measure of regional areas of mucus plugging within the lung or regional areas where ventilation is impacted. And our hypothesis is that exercise will actually improve some of the regional areas of abnormal ventilation that we can see. And we know from previous studies, this is more sensitive than looking at FEV1 directly. So we're hopeful this will really provide evidence of the benefits of exercise, specifically with regards to improvements in lung function over time.
Okay. We're a little bit ahead of time. So they said that we've got another question coming in. So we've got time to ask it. But
Sounds good.
They think interesting that you saw a decrease in sweat chloride. So Hypestrite demonstrated that exercise stimulates ATP secretion, which activates alternate chloride channels. Do you have any thoughts or comments on that?
Yeah, I guess I'd have to look into that paper. I'm not familiar with that. And whether that could potentially impact sweat chloride, I suppose it's possible. I think our thought was that the lower the sweat chloride, the likelier over the long term that's going to predict better health outcomes for people with CF. And so if we can accomplish that with exercise or augment the effects of modulators, and there's definitely some preliminary evidence that ongoing inflammation may blunt the effectiveness of modulators on their impact and ability to restore CFTR function. So if we can use exercise as a tool or a way to augment CFTR function for those on modulators, then that would be an additional reason why exercise may be a great thing for people with CF. But as relates to that specific other chloride channel, I don't know. I'll have to do some digging on that.
Okay. We do have someone else bringing it back again a little bit to the coaching. They were asking if there was any strength training component. Was it more specifically aerobic exercise training? Yeah,
so we left it very broad, depending on what the individual wanted to do. So our goal was really to try and let them guide what their interests were, with the idea that whatever they're most interested in, that's going to be what they're most likely to continue to do. So if someone had strength training is what they're interested in, then we would definitely go with that. The goal was to hit that target heart rate based upon their activity monitor. So whatever activity it was that was going to accomplish that, we just supported whatever their interests were.
Okay. Okay. And then a little bit more specifically about the Garmin devices. Was that something that you guys were providing, or did different patients have their own? Did you have funding to get them for patients?
Yeah, so we had some startup funding that we were provided to purchase those devices. So we did provide them. We wanted to just make sure we had objective measures of the heart rate data and the actual exercise time. As I'm sure everybody's aware, self-reported exercise time is often, unfortunately, overrepresented or not necessarily accurate. So we did have patients provide self-reported exercise time and then correlated that with the Garmin devices, and that was pretty interesting to look at and actually correlated pretty well. But yeah, we were able to provide those for the participants. So,
okay. Do you think that was a product of they knew they were going to be?
Probably so. Yeah, probably so. Right. It's that exactly that they know they're being monitored, so they're probably more likely to tell the truth.
Versus maybe you just have very self-aware patients above average. No. Okay. Well, that's everything we have for you, Joel, and for actually all of our presentations. So thank you to everybody for participating. Lots of really great discussions. Thank you to all of our presenters. We also have Christina and Brian on the back end helping us to run Zoom and Slido and all the different elements to make the presentation possible. So thank you, everybody, for all the participation.